Good afternoon and welcome to the Australian Centre for Value-Based Healthcare webinar, providing the health system with a strategic voice in vocational education and training. I'm Kylie Woolcock, CEO of the Australian Healthcare and Hospitals Association, and it's my pleasure to be the host here today. Before we get underway, I would first like to acknowledge and pay respects to the traditional owners of the many lands on which we meet and recognise their continuing connection to land, water and culture. I'm currently on the land of the Ngunnawal people and pay my respects to their elders past, present and emerging. Reform of the vocational education and training, or VET sector, has been underway since 2018, when an independent review of the sector was announced. That review, the Joyce Review, put forward a plan to deliver a stronger skills sector, which is a positive choice for many more Australians, whether they are starting their working lives or need new skills to advance their career. There have been many parts to this reform. Today, we want to focus on one of the most recent reforms, the establishment of Jobs and Skills Councils. 10 have been established to strengthen the strategic voice of industry in VET, driving collaboration across sectors and addressing workforce challenges to meet the evolving needs of industry. Human Ability is the entity that will be the Jobs and Skills Council for the health and human services, early educators and sports and recreation sectors. Its governance forms a tripartite relationship between employers, employees and government, so that all parties come together to find solutions to skills and workforce challenges. While the entity will have the quality assurance function for training products, what I want to focus on today is the new function, a function that sets the reform apart from the previous system, and that is in strategic workforce planning. Before I introduce our presenters, if you have any questions throughout, please use the Q&A function at the bottom of your screen, and I'll try to get to them throughout our discussions today. Today, I have with me Rob Bonner, who is a director on the new board for Human Ability and as interim CEO has been implementing the establishment of the entity on behalf of a broad consortium of employee and employer organisations. I also have Kath Maloney, CEO of Services for Australian Rural and Remote Allied Health, to discuss the opportunities with these VET sector reforms in the context of the allied health assistance workforce. Unfortunately, Kylie Stothers from Indigenous Allied Health Australia is unwell and unable to join us. First, though, I would like to introduce Yasmin King, CEO of Skills IQ. Yasmin, can you first tell us about the VET workforce in the health sector in Australia? What do we know about this workforce?
Hi, Kylie, and thank you for inviting me to speak today. Look, the health workforce in Australia is one where we have had a focus of looking at skills base, which is different from a lot of the ways other jurisdictions internationally look at the workforce, where they are very focused first on qualifications. If I can just give you a little bit of background on Skills IQ before I sort of launch into details about the health workforce. Our role was we were previously, under the previous system, responsible for the development of all of the training products in the sector. And currently, since that contract is now passing to the Jobs and Skills Councils, our focus is now, if you wouldn't mind going to the next slide, Kylie, we're now focused on doing broadly workforce planning and with respect to policy and strategy, workforce development, and also still technically work in developing training products as well as industry engagement and just general research. And we do that basically for international clients and also private sector clients, basically to capitalise on the skills that we've had in my team for the last 7 years in developing just training products. If we look at the health workforce of Australia internationally and compared to Australia, if we look at US, Brazil, Germany, France, UK, Australia, Canada, etc., and we look at just medical doctors, the really interesting information out of this slide is on a per capita basis, Australia actually has just slightly less than Germany, the highest number of medical doctors per 10,000 of population, which if you look at it from what it feels like as a user of the system, that's actually really quite a surprising stat, right? If we then look at nursing and midwifery, it's we in fact have the highest number per capita of nursing and midwifery personnel. So what can you take from that? I think it's about utilisation. How effectively are we utilising those qualified people in the sector? To do this equivalent for the vocationally qualified people is almost impossible to get that data internationally. And that's because we're one of the few countries that actually has a national set of vocational education qualifications across the entire country. Most of the other countries do it by state or by region, or in the case of the US, there is no national system at all. It in fact is down to various industry sectors and even down to regions within a state in the US. So it's an incredible feature and strength of the Australian system that we do actually have a national vocational education system. If we then look at what the characteristics of the healthcare and social industry is in Australia, and next slide, Carly, you'll see that it's the largest employing industry in Australia. And you won't be surprised that when you hear how much support and funding goes into supporting education in this sector, that does not marry with the fact that it is the largest employing industry. Interesting stats where 76.5% female workforce. That could have very much a reason why it's not the top priority, to be blunt. 57% are in full-time employment, which is lower than the national full-time rate of 66%. We're also, not surprisingly, the average earnings are less than the national average. But I think probably a surprising stat to many in the workforce would be that 45% are university qualified, but actually 31% actually have a vocational education qualification. And you will see that over the forecast period here, particularly in the latter years, you're seeing the significant expected growth in the demand for workers. 15.8% growth versus a national average of 9.1% growth. And that's projected up until November 26. And this is obviously based on the Australian government's labour market data out of their industry labour market portal. Go to the next slide. So where does this workforce work? I mean, it's a very diverse landscape for where people are engaged in the health sector. You can see that there are many jobs where there is actually crossover in the sectors with different workforces and organisations. But this is basically, you'll see that the majority are in the hospital system, then other social assistance services, followed by allied health, residential care, medical services, childcare, and then pathology, and then other healthcare services. Now, many of the largest employing occupations in the industry are actually supported by vocationally educated workers. So, for example, if we look at registered nurses, there is support from people enrolled nursing, individual support, ageing support, receptionists, which is the medical assistants, the qualification is medical assistant qualification, nursing support and personal care workers, childcare workers, and there is an area where there is a significant forecast demand for additional workers, particularly with some of the foreshadowed changes in the government policy. Welfare and support workers, again, significant numbers expected, and also in the things like dental assisting, for example, as well. I'm probably not going to be telling anybody here anything surprising when obviously staff shortages are a key feature of this sector. this has not been something that is a recent phenomenon. It's not a post-COVID phenomenon. This has been something that has been highlighted and talked about for some time. We are also not the only jurisdiction in the world that is facing this. Skills IQ recently participated in an OECD project on looking at forecasting needs in the health workforce internationally, both developed and developing countries, and every single jurisdiction that was involved in that talked about the same sorts of challenges in terms of an ageing health workforce, difficulty in attracting and retaining people, the fact that there was a high burnout rate, and that COVID had absolutely exacerbated that. And so also about some of the ethical challenges in suggesting that what we've got to do is recruit from other countries, and what that actually means for those countries in terms of the ethics of them not having sufficient health workforce staff to meet their own needs. So it's a very complex area, and Australia has not been alone in not really paying enough attention in what this means in terms of workforce planning and development in this space. And there are some significant crunches that are being faced that I think the agenda for the new Jobs and Skills Council to actually look at this in this wider scope of actually having planning and strategy about health workforce as being part of its agenda is something that is incredibly welcome. The previous 7 years has saw the contract that we were responsible as very narrowly restricted to just dealing with training package development. So the new feature is going to be a much broader scope, and that is very, very welcome. Some of the challenges that in addition that I think we all know and are not surprised by is that technology, go to the next slide, is something that is also facing us. We've got a critical need to upskill the existing workforce in terms of technological advancements, and look, and also obviously how can AI be adopted, but in a way that is ethical and productive for the sector. Certainly the work that we've done with a lot of providers, in particularly aged care and disability, show that their biggest challenge in terms of technology is not the capacity of their workforce to deal with it in terms of their capability to learn something new, but actually having the time in terms of their current job roles to expand to learning new systems and processes, because they're so understaffed and under the pump that sometimes trying to add something new into the mix can be almost a bridge too far and contribute to the burnout of existing staff. So there is some real challenges in how we actually deal with this challenge for the workforce. The other feature that I think we need to do more of is looking at how we can learn from other sectors, that cross-collaboration and communication, so that we are focusing on what are the specific technical skills and function requirements that are needed for this workforce, but where can we learn from or borrow from other areas where there may be some things that can be utilised or adopted for the sector. The other feature that we think is really important in the new landscape in this space is that how there can be proper collaboration with all of the players in a productive way, actually looking at what the outcome is for the workforce and not about, what makes it easier for somebody's own business model to get the outcome that they need. We've got to go back to the first principles of what's the purpose. The purpose is about what does the workforce and its clientele need, not about what makes my business work better, and that informing what the training product should be and how it should be developed. So I'm happy to take any questions. I hope I haven't sort of put too much data up there. Happy to discuss.
No, thanks so much, Yasmin. And I think you've highlighted just how enormous the workforce is. And our next up, I've invited Kath to speak with us before we come back to you to talk further with questions, to talk about one part of the workforce. And I think what we'll also see is that some of the issues can be quite shared across different parts of the workforce, but also there'll be some that are quite unique to different parts of the workforce. So I'll hand over to you. Thanks, Kath.
Thanks, Kylie. And I'd like to start by acknowledging the traditional owners of the lands on which we're all meeting today. I'm joining from Camaragal land here in Sydney today, and I pay my respects to elders past, present and emerging. Thanks for this opportunity. Just before I launch into this, Services for Australian Rural and Remote Allied Health is a peak body representing rural and remote allied health professionals, and we've been around for about 28 years. We have a couple of projects that we are delivering on behalf of the Commonwealth Government. One is looking at expanding the allied health rural generalist pathway in non-government and private settings nationally. And we also are doing a piece around growing the allied health assistant workforce in collaboration with allied health professionals. So we're looking to increase the uptake of allied health assistant roles by allied health professionals, working particularly in Modified Monash 3 to 7 areas. So next slide, please, Kylie. I won't go too much into this because Yasmin provided an excellent overview, but I will highlight that we're often, whenever we're talking about training opportunities and jobs and skills growth, everybody's thinking about the hard hats and high vis vests, but in fact, as you can see here, the healthcare and social assistance workforce is the largest growing workforce, and the orange arrow down the bottom there is mining, which is well down the list in terms of where we're expecting to see the growth happening. So next slide. Yes, I won't go into too much there. So as an example, with the allied health workforce, I'm going to take one discipline, being podiatry, as an example of some of the workforce shortages and maldistribution that occurs with the allied health workforce. So podiatry is one of those where we have seen some growth in the workforce overall over the last 5 years or so. But in fact, what's happening is that workforce is becoming more highly concentrated in metropolitan areas. And so, as you can see, there is a dramatic shortfall that occurs as soon as you move outside of a metropolitan area. This is significant when we look at where the burden of chronic disease is carried by the Australian population. Rural and remote areas of Australia carry a higher level of disease. So when you're thinking about things like diabetes and the associated high risk foot that comes with diabetes, the ability to be able to access a podiatrist for that high risk foot care is critical. And we do see increased rates of amputations in relation to diabetes in rural and remote areas. So there is probably a cause and effect there. We're also seeing that in the absence of a national allied health workforce strategy, that we see continuing challenges in terms of the number of undergraduate students coming through the ranks. And so we're not sure that we're going to get the right or the growth of the workforce where we are needing them, particularly in rural and remote areas. So, so in short, in relative terms, the maldistribution of the allied health workforce is worsening and very substantially, and there's an immediate need for a national allied health workforce strategy. So thank you, Kylie. So one of the things that we are seeing a lot of growth in demand for, though, is allied health assistant roles. So an allied health assistant works at a certificate 3 or 4 level. They work under the delegation of an allied health professional to assist with therapeutic and program-related tasks. Now, delegation is a defining feature, and it's fundamental to the definition of an allied health assistant role and safety, patient safety. So while allied health assistants work within clearly defined parameters, the role is often flexible and involves a mix of direct patient care and indirect support activities. The mix of duties is determined by a range of factors, including the model of care, the needs of the professionals that are delegating the work to the assistant, and the types of services that are delivered by the allied health team. Allied health assistants may work in either profession-specific roles, so they might work specifically with a physiotherapist, for example, or they work as a pharmacy assistant, or they can work in a multidisciplinary capacity, for example, as a rehabilitation assistant that works to a number of different disciplines. That they could work to the physio and the speech pathologist and the occupational therapist. Allied health assistants may provide support and mentoring to less experienced allied health assistants, and they may have a role in supervision. Next slide, please, Kylie. So the demand for allied health assistants is growing rapidly. If you were to do a search on Seek today, you'd see probably 3,000 plus allied health assistant jobs advertised weekly. But despite this, allied health assistants were not included in the national skills priority list. So, so we need to make sure that there's some amendments to that, and or that we work with the state jurisdictions to ensure that we see the growth that we need in the training opportunities for allied health assistants. There are currently no national training competency standards to support this rapid growth. Now, there are pros and cons to nationalise training and competency standards. We need to be able to support on-the-job training of allied health assistants while they're working towards certification. You know, if we were to ensure that somebody held the qualification before they started working in the role, then we're going to have a pinch point there where we need to be able to grow and have access to these services very rapidly. So there needs to be some flexibility in the system there. We also need to consider the priorities for Aboriginal and Torres Strait Islander communities, where English may be a second or third language. So there needs to be flexibility to enable people to be working in the role with appropriate supervision and training, but not necessarily working towards certification. Now, just in the last couple of months, we have had the establishment of Allied Health Assistants National Association, or AHANA, and incorporated to support allied health assistants to improve the output, quality and efficiency of allied health professionals and allied health services provided publicly and privately across all settings: health, rehabilitation and aged care and other care settings across Australia. So AHANA is working towards self-regulation, including the development of national training and competency standards, and we're very supportive of the work that AHANA is doing. Next slide, please. So when we're thinking about how to develop and implement allied health assistant roles, it is quite a complicated process. It's not just a matter of saying to an allied health professional, here's the allied health assistant, off you go, start working with them. There's a lot to be considered in terms of the workplace design, the service model design, the governance around that act of delegation of allied health professional tasks to the allied health assistant, and the amount of supervision and support and training that is required to enable that allied health assistant to take on work on behalf of the allied health professional. So some of the work that we're doing through our project is working alongside of service providers to help put some of these structures and supports in place. And we pay a workplace training grant to the employer that offsets the cost to the employer in setting up these supervision and support arrangements. Now, there are some great examples, I will say here. Unfortunately, as Kylie mentioned, Kylie Stothers wasn't able to join us from Indigenous Allied Health Australia. The IHA is doing fantastic work in growing allied health assistants who work as part of community in Aboriginal and Torres Strait Islander communities. The model picks up allied health or students in middle high school, and as they undertake the high school certificate with an interest in a health career, and they work with those students so that they are completing a Certificate 3 in Allied Health Assistance as part of their higher school certificate, and then help to support those students, those graduates, into employment after they finish school. And so this is a fantastic model that is working very well for IHA in growing an Aboriginal and Torres Strait Islander workforce that is culturally safe and responsive. So that is probably the gold standard in terms of what's currently available. You know, there are other great examples that I've been involved in previously where similar models have been happening, employing students coming out with the HSC with a Certificate 3 in Allied Health Assistance and going straight into secure, well-paying jobs. And in view of all of the information that Yasmin provided earlier, it's critical that these pathways are shored up and supported. So next slide, please, Kylie. I think this is the last one. So some of the challenges I think that we're facing at the moment, our sector particularly, is with this rapidly growing allied health assistant workforce. We're seeing registered training organisations that are moving ahead in response to the sector demand. So there is this rapidly expanding choice, I guess, of training that's available to allied health to develop the allied health assistant workforce. And this may in some respects be outstripping the allied health sector in terms of our capacity to accommodate this. Now, the reason for that is because particularly in private non-government settings, the practitioners are often constrained in terms of the sorts of jobs that they can give allied health assistants to do because it is not funded. So the only area that recognises and funds clinical work undertaken by an allied health assistant is in the disability sector, but we haven't got similar capacity in aged care, in primary healthcare settings, chronic disease management, where we would really want to see the deployment of allied health assistance. There are some funding issues there. There's also a shortage of trainers, and this is a significant pinch point for us. So ideally, we would be saying that allied health professionals need to be part of that training. That's going to be helpful not only to the allied health assistant in understanding the scope of the role, but also assisting the allied health professional who will ultimately be delegating work to that assistant about what that person is capable of doing and what they're clinically safe and competent to do. And then finally, the allied health sector as end users of allied health assistant training need to be closely engaged in the training and provision of clinical placements. So this is including things like support for on-the-job training of allied health assistants by allied health professionals, And there needs to be consideration of the supervision, support and governance of allied health assistance by allied health professionals to ensure the quality of allied health service provision is maintained. So that recognition that supervision and support as part of a model of care needs to be factored into the remuneration for the services being provided. Thanks, Kylie.
Thanks so much, Kath. And I mean, that was a really great example of how important it is that policy levers align when we are developing roles like this. It's not just the training that's important, but how that's then embedded across the system. And I'll invite Yasmin back as well, because I know we've had these conversations in the context of medical assistance. Can you talk about that role in terms of, a training package was developed, but the policy levers themselves didn't align, similar to the way it is with allied health assistance? Sorry, just on mute.
Sorry about that. You would think after now I would have learnt that. Look, I mean, that the medical assistant qualification has been around for some time. It actually was first released in February 2007, and it's been had a major change, I think, in 2015, a revision. It's a Cert 4. And part of the role is essentially support to a medical professional in terms of some of the administrative functions, taking clinical notes at the direction of a medical professional, etc. If I look at what the latest stats are in terms of enrolments sorry, I've just printed this off somewhere else. I'll just tell you. It was in, we had 700 enrolments and 76 people who actually graduated with the qualification. Now, part of this is because there is no funding incentive for someone to want someone who is qualified in this space. If you look at primary care, for example, the way we structure primary care, and I mean, it also applies to things like enrolled nurses in that practice and nurse practitioners, our funding model is not set up to basically from everybody operating at their scope of practice. And what Kath has just has outlined in terms of allied health professionals is exactly the same, right? You can have people who identify as saying, I can see that as a career path that I want to start on, and they may go and get the qualification. But if our funding model doesn't match your ability to use that as a pathway and a support, then people will start something and then basically walk away from it because they don't see that there is a career path and potential for them. So, I mean, in so many places across the health system, we are not leveraging the capacity of those that are vocationally qualified effectively, not because they haven't got the right skills, but because the funding models don't allow their proper utilisation. And I mean, even in some of the hospital systems, we hear anecdotally that there, even though enrolled nurses have a very comprehensive scope of practice, also registered, because AHPRA actually registers enrolled nurses. And so in our experience, the quality alignment of the outcome of the training is much more consistent because there is a third-party registration process. However, there's even in some of the health systems, we hear that a hospital system is saying, well, we're just going to, it's too hard for us to manage enrolled nurses and nurses. We're just going to go with a complete nursing approach. And that, I mean, that's not a way to basically have a proper development of your workforce, because you also are eliminating a really clear pathway for people as well. So, I think there's lots of challenges in this space unless we can align the funding model to what the actual workforce needs are.
Kath, did you want to add any more to that one?
No, I think Yasmin summed that up very well. There are so I think because we do need to see this rapid growth in workforce, and allied health assistance is certainly part of the solution for the allied health services and the allied health sector, and that notion, not just around the funding, but also that we need to see support for the training, the teaching and training that occurs in the workplace, both of the assistant workforce, but also of students and of early career. So that senior allied health professional providing supervision and training and support and mentoring to the early career allied health professional. And we don't have any of those supports in primary healthcare, in primary healthcare outside of what happens within health services.
Yeah. We're also seeing variations between jurisdictions, which I think we've picked up on as well in both of your presentations. And this can provide an indication sometimes of where other policy levers are impacting on the workforce. I think the skills priority lists are possibly one of those. Yasmin or Kath, would you like to speak about some of these, the variation between jurisdictions that you see?
When you say variation, do you mean as in between the states?
Yeah.
Yeah. I mean, look, one of the things that is certainly occurring in the workforce space at the moment is, let's use Victoria as an example, where they are prepared to, for example, pay the HECS fees of all nurses. All right. I mean, essentially, that's not going to take nurses away from, bring them in from the international market. That's going to be, basically one state taking from another. In fact, if you look at the marketing campaign that South Australian Ambulance undertook for its shortage of ambulance professionals, it marketed to other states, come and relocate to South Australia. We're robbing Peter to pay Paul. We're not. What we've got to do is have a much greater focus on growing our own workforce, right, from the ground up. And one of the biggest challenges that we hear about is the fact that from training providers who will say, look, we basically have to let students go and find their own work placement, right? There isn't a coordinated approach for work placement opportunities for students. And if you go and talk to some of the health systems, they'll say, oh no, look, it's too much risk for us to take on a student. We're not interested. We're wanting somebody who's N qualified, preferably even experienced. And we've got to change this mindset, right? There's got to be an understanding that we need to start growing people through the system. And as Kath was saying, have better utilisation of supervision and mentoring for them so that they actually grow up within the workforce and not, expect that they're going to basically come out of a training provider wrapped in a neat bow and then be able to go and start work from day one. I mean, it's unrealistic. So I think that's one of the really big challenges for the sector, is to work out how they can really embrace some of those issues. And if I look at, for example, traineeships in the aged care and disability space, right, they're less than 1% of the workforce. Okay, if you look at New Zealand, it's 15%. If you look at the UK, it's 20%. So we are so far below because we don't have a culture of let's take people on while they're early in their learning journey, support them while they train on the job as well as at a training provider to then actually be qualified and really adding value in the workplace. And it's also why some people go through a training provider, get qualified, then actually the first time, and I don't exactly know how this happens because there's supposed to be proper workplace assessment, but we do know that it happens from employers telling us, is that they'll start in a workplace and go, oh, this isn't what I expected. No, I didn't think this is what my job was going to look like. And they leave. And you've lost them then forever. So I think, we've really got to do better at building an ecosystem to support people learning on the job.
Kylie, I'd just like to add to that by saying for allied health assistants particularly, it's probably not so much the jurisdictional differences, but the service settings. So as I mentioned earlier, allied health work across all sorts of settings: disability, aged care, education, private primary health care, hospital settings. And the focus and the skill sets are slightly different in each of those. And then sometimes you get some service providers, particularly in rural and remote, who do a bit of all of that. So it's the variance across that that service setting, and therefore, you know, the broad scope of practice that's required both by the allied health professional and the assistant that I think needs some attention.
Okay, so this is a good time to move on to introduce Rob. And I mentioned in my introduction that one of the new functions of the Jobs and Skills Councils will be strategic workforce planning. It has been identified by the department as a centrepiece of their functions. Rob, we've just heard how large and diverse this workforce is, and that the Jobs and Skills Council also covers human services, early educators, sports and recreation. What can we expect from human ability in this space? And I'm just going to share your slides.
Thanks, Kylie. And while you're doing that, I just want to also add my acknowledgement to the traditional owners of the lands on which we're variously gathered. In my case, it's the Ngarrindjeri people. I'm speaking to you from my home in Hindmarsh Island in South Australia. So greetings to you all. Next slide, please, Kylie. As you've heard, Human Ability is the new Jobs and Skills Council that covers a huge part of industries across the country, from early childhood education and care, health, human services, including aged care and disability care and support, and the addition of sport and recreation. I think Yasmin mentioned that we're about 15% of the total workforce across the country, and we also are responsible for about 15% of GDP in the economy. And I completely support the contention that I think we've heard so far, that we have been grossly under resourced for that proportion of both economic and workforce participation. Next, thanks. So how are we formed and how are we different from the old organisations, the service skills organisations and the IRCs? We are a tripartite body, so we are a company that is owned by a mix of our members who are employers, employer associations, unions, and we also have in our mix some consumer organisations and peaks that give us feedback from the end user perspective. The third sort of formal part of that tripartite triangle is, as people have mentioned, governments, because they're ultimately our funders and our regulators. We've got around 200 stakeholders from industry that are already registered with us through that process, and that's a pretty informal exercise at the moment that we're about to get a bit more organised about. So next slide, our structure. So we are, as I said, a membership-based organisation. We have about 30 voting members, the foundation members of the organisation. Our board, which met for the first time this week, and I just want to acknowledge on the list of listeners is our new chair, Deborah Cole from ACHA. So I know Deb's listening, and hopefully my performance meets her expectations. Our board is a mixed board of 5 independent members and 4 representative members, 2 from unions and 2 from employers. We will be establishing, as we get through the establishment phase, 5 advisory committees that will work to the board and lead industry advice. 1 for the health sector, 1 for the human services, 1 for sport and rec, and 1 dealing with early childhood matters. The 5th group is the group that we hope will pick up responsibility for leading workforce matters projects and product development that cut across all of our sectors or need to intersect with other Jobs and Skills Council. And on top of all of those, we will be having 3 new forums established, 1 for training providers in our sector, one for students and recent graduates from programs, and one for what we're calling industry leaders, those sort of thought leaders, people who've got a vision for reform and future development of models of care, models of service delivery that we need to be looking forward to make sure the workforce can meet their needs. And finally, the sort of stakeholder networks that you've all been engaged with in the past, industry reference committee, technical advisory groups, and the like. Thank you. So this week, so we got our contract to start this new organisation on the 19th of December last year, just as everyone that we needed to help us establish the company went on leave over Christmas. And we've been working for the last 3 months in setting the company up. Yesterday, we filed our phase 1 report to the department. So we're now a company that's registered. We've got a board in place. We've got all that sort of mechanical stuff done. The sort of questions that I'm seeing in the chat and getting indirectly around when will we start to see the actual work beginning, we're working to a time frame of taking up our new role on the 1st of July this year. So the actual sort of workforce development activity, training product reviews, advice to industry in terms of training packages and the like is mid-year. Thank you. As people have mentioned, we've got a wider role than has been the case in the past. Workforce development policy, particularly around future jobs, skills and demand, forecasting, working with Jobs and Skills Australia in taking their national database of research, testing it with our industry, testing it in regions, and putting some end user narrative around that to make sure that the quantitative data is put through some qualitative measures through our stakeholder engagement, and meaning that we're applying it well to our industry. A workforce development approach rather than qualification design alone. We all know that training itself is not going to fill the gaps in our workforce. We need to improve attraction, we need to improve retention, we need to improve utilisation of skills. As I was hearing Yasmin earlier, the number of nurses, because that's my patch, that she talked about being one of the highest internationally. We also have the highest rate internationally of part-time work in the profession. So in Canada, for example, 90% of registered nurses work full-time. In Australia, 66% work part-time. So that has a clear message in terms of utilisation of that skill over time. We all need collectively to get ready for industry leadership. Government set up this new model on the basis that it wants industry, that is employers and employees, to work with our Jobs and Skills Council to give them advice about what skills, what jobs, what reform need to be there. We have to be prepared to be accountable for that, but we've said that we want freedom to act within the guidelines, and we've certainly said to government and the regulators that the expectation of you as our stakeholders is high. So currently we're engaged, as I've said, in building capacity and leadership, getting our systems right, and people have been generous from across our industries in terms of volunteering. As I said, we're up to over 300 stakeholders have re-registered to be part of our advisory committee processes. Next slide, thanks. So some thoughts about our priorities, and I'm acknowledging that it's early days. We will be required to put in our first workforce plan by towards the end of April, beginning of May. And we're working with Yasmin and her team at Skills IQ in terms of utilising the data, looking at some of the material that came out of the old IRCs, and building a picture of workforce and what priorities for workforce development are. And amongst those are, where will we get the workers from? You saw some of the data from Yas earlier around vacancy rates and demand. Our vacancy rates across all of our industry sectors are through the roof, and the future demand forecast in almost every case is frightening. We've got improved staffing levels that are going to be required in aged care, disability services, childcare, and in a range of the professions that will require more workers. Where are they going to come from, given the competition with other skills areas? We're looking at how we can tackle some of the shared issues across our sectors and then drill down and make them apply across the board. We've Yasmin mentioned the effects of COVID. The effects that are showing in the research in terms of burnout, stress levels, retention, intention to leave are significant, but that builds into that whole issue about the state of mental health, burnout and stress within our workforce as a whole. And then we have to deal with retention. So what are driving people out of work, reducing their participation rates that we can help with, that will take the pressure off the front end in terms of skills and new people on the way through. There's a bit of a stretch factor there in terms of our job role, in terms of how much influence, but we can at least signal to employers, to regulators, to unions, the kind of work that they need to be doing in their own space to boost retention in our space. So thanks. Next slide, Carly. Some early thoughts that we've already started talking about in terms of projects, and some of that resonates with the allied health assistant conversation that I heard. How can we escalate skills quickly and safely? So we've got a lot of reliance on novices in our systems, but we're losing people with higher order skills. So we're getting the neophytes in and losing the experts. So how do we get those people in and get them up to a level where they become workplace leaders, specialists, and have higher capability? How can we make the skills transferable but also relevant to the specific purpose and role? And there's an emphasis at the moment in terms of some of the conversation around training products about eliminating some duplication. So it's how do we do some of the improvements to transferability and not lose the value in terms of the focus of the qualification. And as I said, our industries do feel overlooked. We're a huge segment of the workforce economy, but we've lacked investment. So arguing for a greater share of the sources at the front end is a focus. Thanks, Carly. So what you will see from us, and this is I think my sort of final pitch, we will be finalising stakeholder engagement strategies and plans for the coming year or three, and that will be released, I'm hoping, by the end of April. That will allow us to start the process of forming our advisory committees that will be in place by July. And as I've said, we'll be required to produce our first workforce report. It's a high-level desktop limited engagement piece of work, just because of where we are in the formation cycle this year. But we hope that we'll be releasing some of the key messages from the initial analysis by the end of April for your urgent feedback. By July this year, we should have our leadership team in place, our year work plan improved, and be ready to do the real work for you. As I said, some expectation management. We've been told that the training product development, the actual qualifications and competencies, is likely to be restricted in year one. So we're looking at what the urgent and outstanding work is that we need to be including in the work plan. And as I've said, we're looking at some workforce development projects and priorities to address some of those major themes arising from the analysis of data and our first workforce plan. Thank you. And hopefully next time I'll have a bit more to say about the content rather than hiding behind some of the formation.
Thanks so much, Rob. I'll invite Pat and Yasmin back. We've got a few minutes before the end of the session, but I guess I wanted to focus on what it's going to take for these reforms to be genuinely successful. We're seeing some questions come through, and it's been raised by you already around how do we build the customer, the end user's perspective about the use of, and the question was specifically about allied health assistance, but do we have information about from the consumer's perspective to inform some of this work?
Some of it we do, and we certainly have access through our stakeholder networks to consumer advocacy organisations like Council of the Ageing, Seniors Australia, a range of other regional and allied health service consumers. So I think we can reach out, but we need to become a bit more structured about that in the coming year or two.
Great. Sorry, Kath, did you know if there was any specific available around allied health assistance?
I would have to go, digging back into my memory from about 15 years ago, yes, I think there has been evaluations that capture the consumer experience, the client experience, and yes, there is a high degree of satisfaction for services delivered by allied health assistants. I'm sure that there are some jurisdictional evaluations that have been done as well. I'd have to go digging for those. We can go looking and provide those linkages to you, Kylie, afterwards.
Great. And we might have to do that with some of the questions that are coming up. We'll certainly look to come back to you with answers to some of the questions. But I guess I wanted to look at one of them that was around, given that there is this shortage in the workforce, assessor requirements. How are we going to have the workforce that will even assess the development, not just supervise, but actually assess them?
From an allied health perspective, one of the things that I think could be a solution here is, if we can resolve this issue about place-based training and education for allied health assistants by the professional, then you're going to be covering off that issue about competency assessments at the same time. So if the workforce is being developed by allied health professionals, they're providing that on-the-job teaching and training, they can also be involved in the competency assessments. So that is a way, and particularly if we're addressing some of those remuneration issues, that's a way of increasing the supply of people who could assess allied health assistant competencies.
Thanks.
Yes. That kind of co-assessment model is something that's already in place in some other areas, like nursing. So
Right.
the registered nurse who supervises students on placements is also contributing to the ANMAC registration assessments, as well as the competency assessments on the way through for enrolled nurses. So I think the models are there, and it's about how do we adjust some of those existing models and make them more relevant and applicable for areas like allied health.
We only have a couple of minutes. Sorry, Jasmine. I was going to say we only have a couple of minutes left. So can I ask you to make some final remarks on what do you think it's going to be to effectively engage with the stakeholders across our sectors with these new jobs and skills councils? And we'll start with you, Jasmine.
Look, I think the opportunity is there for, given its wider remit, to actually point out some of the challenges. And part of that, some of it's industrial relations, some of it's basically giving feedback on cultures of workplace, business models, etc. Its wider remit is going to be able to sort of, because I think there's been a tendency in the past to say, if there's a problem, it's all about the training package. The training package is one small component, right? It cannot be the answer to everything, right? It's a whole ecosystem. So I think that's one of the really positive things that can come out of this, provided that people basically get on board to basically adding the value of the process, and not about, well, it's not suiting exactly what I wanted, and so therefore, I'm not going to participate, or I'm going to basically, be critical. I think, if all of us as consumers, and basically all of us at some point are, want a good outcome, then it's up to all of us to basically ensure that we're putting forward what's needed and the outcomes that need to be achieved.
Yeah, thanks. Kath, I'll leave you to last, Rob.
I would be suggesting that we'd like to see close engagement from between the trainers and the RTOs and the people who are developing curricula with the allied health sector. So I'm perceiving that there are conversations and developments happening that are a little bit disconnected. So there's a tendency to push to produce allied health assistance without necessarily having the allied health sector engaged there. So we've seen this in the past where roles and qualifications result in a workforce where there's not necessarily a place for them in the industry. And I think the solution to that is to make sure that the allied health professional sector is involved in these developments as they progress.
Thanks, Kath. Final words from you, Rob.
Thanks. I think that the biggest challenge for us is to get people to look far enough ahead that allows us to reposition some of the conversations about what does the future workforce look like to meet what models of care, what levels of demand, and then set some routes and ways to get there. That is realistic, it's measurable, it's adjustable over time if things shift, that deals with the sort of issues like funding models, regulatory systems that people have mentioned. And that's really tough when people are drowning in the stuff that is the health system of the day. So the challenge for us is to create an environment, I think, where we capture that future focus, the current levels of distress, and plan a way through it. And I think that will give us, if we can get there, that will give us some hope and commitment and buy-in from our people.
Thank you. And that's a perfect note to leave on. I hope, thank you all so much for contributing to this webinar this afternoon, and thank you all for joining us. It's only the start of the conversation though, so we do look forward to working with you all as this develops. Here at AHHA, we host regular webinars on topics mostly around value-based healthcare, which, as Rob has said, that's the models of the future, models of care of the future. Our next webinar is actually on the 29th of March, and it's focusing on redefining hospitals in the health sector to drive value for people, communities and the system. And we're going to be joined by the former CEO of Healthcare Denmark. It's a system that's done just this, and over a period of 20 years went from 98 to 32 hospitals. Obviously, that means an increase in the care that's provided in community. And so there'll be a panel discussion with Australian healthcare leaders to discuss the Australian context. You can find out more about our events and activities on our AHHA website, or you'll get a follow-up email to this one with a link to the presentation that you've had today. So thank you so much for joining us. Thank you, Rob, Kath and Yasmin. It's been wonderful having you, and we look forward to seeing you all again at future webinars.
Thank you.
Thanks very much.
Thanks.